Uncommon causes of white spots. Tuberous sclerosis. Tuberous sclerosis, or tuberous sclerosis complex, is a rare, autosomal dominantly inherited, neurocutaneous disorder that can affect multiple organ systems. Expression of this disease varies widely, however, the classic triad consists of seizures, intellectual disability, and angiofibromas, also called fibroadenomas, previously called by the misnomer adenoma sebaceum. Classic skin manifestations include white macules, angiofibromas, shagreen patches, and periungual fibromas. White macules are important diagnostically because they are usually present at birth. Tuberous sclerosis, white ash leaf macule. They appear as hypopigmented macules, ranging in size from 1 to 3 centimeters. They are often shaped like a thumbprint or an ash leaf on an ash tree, oval at one end and pointed at the other. They are most often found on the trunk and less often on the face and extremities. Patients may have as few as 3 or as many as 100 lesions. The spots are most easily seen with Wood's light examination. Sometimes, particularly in infants with extremely fair skin, this is the only method of detection. Therefore, all infants with a seizure disorder should be screened for white spots with a Wood's light examination. Tuberous sclerosis is strongly suspected if more than 3 white spots are detected. Angiofibromas typically begin in childhood and appear clinically as red papules on the face, often confused with acne. Tuberous sclerosis, angiofibromas of the face. Definitive diagnosis is hard to achieve given the variation in age and severity of the various manifestations. The disorder is caused by mutations in tuberous sclerosis complex genes, TSC1 or TSC2, which code for the proteins harmartin and tuberin, respectively. These gene products are involved in cellular signaling mediated by the mammalian target of rapamycin, mTOR, and aberrant mTOR activity leads to tumor formation. Therefore, topical sirolimus, an mTOR inhibitor, can be used to treat the angiofibromas that are associated with this disorder. Angiofibromas and ash leaf marks in tuberous sclerosis. Periungual fibromas and shagreen patches in tuberous sclerosis. Hypopigmented mycosis fungoides. Mycosis fungoides, MF, is the most common type of cutaneous T-cell lymphoma. Hypopigmented MF is more common in patients with darkly pigmented skin and those of Asian descent, and is the most common variant of MF in children. Patients often present with patches that have been diagnosed as nonspecific eczema. Although the patches of MF are characteristically erythematous with fine scale, they can appear as hypopigmented patches. The skin lesions have a predilection for sun-protected skin, like on the buttocks, hips, and trunk, and can evolve into plaques or tumors. If a dermatitis fails to respond to topical steroids, especially when located on the trunk, a skin biopsy should be performed to confirm the suspicion of MF. Hypopigmented mycosis fungoides, hypopigmented patches located on the trunk. Idiopathic guttate hypomelanosis. Although this is a relatively common condition, it is underrecognized by physicians. The lesions appear as well-demarcated, small macules, like sprinkled confetti. They appear most commonly on the shins but may also be found on the forearms. In rare instances, the face is affected. There is no effective treatment and unlike vitiligo, spontaneous repigmentation is not observed. It is considered a normal part of the aging process and is hypothesized to be in part from chronic UV exposure. Idiopathic guttate hypomelanosis typically presents as smooth pale, hypopigmented, or white, depigmented, macules 2 to 5 mm, range up to 1.5 cm, in diameter most commonly on the sun-exposed aspects of the forearms, shins, and V of chest. Lesions are usually multiple and asymptomatic. Idiopathic guttate hypomelanosis, confetti-like, white macules on anterior shin. Leprosy. Leprosy is a chronic infectious disease caused by Mycobacterium leprae, a slow-growing, obligate intracellular bacillus with an incubation period of 2 to 10 years, occasionally up to 20 years. It primarily affects the skin and peripheral nervous system. Transmission is thought to occur via nasal droplet spread, though the exact route remains incompletely understood. Over 200,000 new cases are reported annually, with the highest burden in India, Brazil, and Indonesia. Often the earliest sign is a solitary hypopigmented macule. The earliest sensory change is loss of feeling to light touch and cold in the hands and feet. Nerve involvement is a disease hallmark. A biopsy with special stains, phyte stain, for the organism confirms the diagnosis. When skin biopsies are inconclusive, a polymerase chain reaction test can be performed to identify leprosy DNA in tissue. Leprosy, asymmetrical distribution of hypopigmented plaques and patches.
Clinical case. This 25-year-old woman was seen in the dermatology clinic in October, with a 4-month history of white spots on her upper trunk. With sun exposure over the summer, the spots had become more noticeable. They had not been red or symptomatic. What is the most likely diagnosis? This patient has a typical history for tinea versicolor. Scratching the affected areas elicited a fine, crumbly scale, further heightening the suspicion of tinea versicolor. What test would you do? The potassium hydroxide, KOH, preparation is diagnostic, revealing numerous short hyphae and spores. How would you treat this patient? Fluconazole was prescribed in a single 200 mg dose and repeated again in 2 weeks. The skin gradually repigmented over the following 3 months. Prevention of recurrence can be achieved with periodic washing of the affected areas with zinc pyrithione or selenium sulfide shampoo. Localized areas may be treated with mycotin cream.